now going to speak to some of the research that he's been doing involving videoing people in actual hospital spaces.
Well, not only that, I think the Australian Research Council project that I'm working on at the moment, which is a 3-year project, it goes, I hope, will go some way to doing what Sarita has just suggested, is trying to get that evidence into practice, but also bridging a gap between how people experience health facilities, not just from the patient's point of view, although that is crucially important because they are now recognised as a member of the team, but from a staff member's point of view. And we know now that interaction between healthcare professionals and patient is a critical link. Somewhere there, a critical link in clinical risk, which is a major issue facing our healthcare services, and mitigating against that clinical risk. And when I talk about clinical risk, I talk about mistakes happening in hospitals. Because people who work in hospitals are human beings, and mistakes will happen, and sometimes it won't be anyone's fault. But what we've got to do is we've got to provide an environment that is conducive to positive interaction, so these risks, they'll never be destroyed, they'll never disappear completely, but we obfuscate them as much as we possibly can. The grant is called Organisational Complexity, the Built Environment and Clinical Risk, which I think I just summed up quite nicely. We have a couple of objectives. I'm going to be very quick on these, but basically we want to bring experience at the end into how we go about looking and building new environments. You think about the investment of an infrastructure of our money, taxpayers' money, into building these facilities and how long they're expected to last, and often they last well past their expected planning date. You mean you build a hospital and you're thinking, oh, we'll plan for 30 years. Well, RPA, Queen Victoria Ring, is a perfect example. We have an emergency department there, and I think the numbers outside outside the building say 1820. So when they built this place in 1820, I'm sure no one was thinking, well, in 2009, how are we going to be providing care? So we're going to think about these things as best we can. We're never going to be perfect. And we need to conceptualise and articulate the links between how we interact as healthcare professionals and clinical risk and the space that influence it. We want to let participants drive the redesign of work practices and enhance patient safety, but within the context of where we provide services, whether it be an outpatient department, an emergency department, an ICU, medical surgical ward. We need to think of people as populating spaces and working within those spaces, doing the best they can in often difficult situations. I'm going to show a short clip here. This is of some video work that we did do in an intensive care unit in Sydney. And it's very short, but just as we go through, oh, if it works, very short. There we go. If you just look at the people in the space, and look how many interactions are happening at once. See if you can count how many interactions and communication there is. See if you can guess who the professionals are. I know we've got a few doctors back there, we've got some nurses. This looks to me like a ward club. A patient, and a family member, a nurse. Good line of sight, huh? Again, another patient with some families who may be in a difficult situation. And again, more healthcare professionals interacting. And there's interactions happening behind curtains and down by the bedside everywhere. So we are going to apply two methods here. What I like to call research arm and research B. Research arm is we want to collaborate with everybody involved in how they build hospitals. Be that be managers, policy makers, healthcare professionals, architects, designers. We want to generate a dialogue and see what actually happens. And the thing that Sarita was talking about is this floor plan and then the finances set and the processes that go through. We really want to understand that. And a lot of people are moving towards getting stakeholder engagement and feeding that into the build process. Well, a question I ask you, and I put this to a lot of people in this room, is what is the quality of the interaction? How does it actually manifest in the end built environment? And what does it mean for people who are participating? We also want to inform the process. So we want to ask the end users, we want to talk to Alan Garlow's nurses and say, and doctors and physiotherapists and say, what is it about the space that you like? What is it about the space that you're working in that makes you feel safe in your practice and makes your patient feel safe in your practice? Or what is it not about the space that you're working in that does not make you feel safe? Very briefly, I'm looking at 4 outcomes here, and these are likely to change because we're in the research process. But what we expect might happen is we're going to be able to very clearly articulate the needs of end users. Not necessarily the preferences or the expectations, although I'm sure we'll get a lot of that, but what they need. And that's all end users. We want to conceptualise contemporary health facility design process. What is it that we are doing? Where is the evidence? Raise awareness about designing for adaptive organisational systems, which I've not had a lot to talk about. If you think about the way healthcare practitioners deal with the sometimes overwhelming wave of complexity that they face every day, sometimes they've got to be fairly flexible. And we want to build collaborative communities of design and practice, which is kind of why everybody's here today, I hope, is that we can start talking about this and start generating a discussion about how we move on from here. So I'm looking forward to hearing from everybody in this room in the near future. And that's how you can get in touch with us.